You can start. Thank you.
Okay. So I'm Shahzya Chaudury, one of the haematology consultants in Glasgow, and I am presenting a sort of whistle-stop tour of morphology this afternoon. So it's a flavour of the kind of things that we see in Glasgow. There'll be lots of pictures, and almost all the pictures are real cases that have come in through the lab. So just take you through what I'll talk about. I'll show you a normal blood film and the kind of things that we look at, and then we'll go over some examples of red cell abnormalities, some white cell and platelet abnormalities, and I'm hoping that by the end of the session, you'll get an idea of the kind of things that we look for in a blood film, and you'll be able to picture some of the descriptions that we use when we issue our blood film reports. So the first thing is we'll go over a normal blood film. So the way that we make a blood film is we pop a little spot of blood from the full blood count sample onto a slide, and then we use another slide to smear the film across the slide. It's then fixed with methanol, and then it's stained with an acid-based stain. So the basic dye stains nucleic acid blue, and that kind of gives a bluey and dark appearance to the nucleus. And the acidic dye stains hemoglobin red, a red-orange color, and that's why red cells are called red cells, because they stain red with this acid dye. And it also stains granules in an eosinophil pink. So that's the stain that we use in our lab and pretty much all hematology labs worldwide. So we have triggers to make a blood film. So if it's requested or there's clinical details, then it will cause the lab to reflex make a blood film. So clinical details such as easy bruising or petechial rash or pallor will immediately trigger a blood film to be made. If the parameters are at with the normal range, unless it's a known patient, that will trigger a blood film to be made. So a new hemoglobin or leukocytosis or a low count. When we do the blood film, we get an idea of what the cells in the blood look like in terms of size and cellular complexity. And some cells, such as blasts, have a particular appearance on this flow. So if there's appearance on the flow that suggests that some of the white cells are looking morphologically abnormal, even in the absence of there being an abnormality in the blood count, that can also trigger a blood film to be made. And when a blood film is made, it's reviewed by a BMS or a hematology scientist. And if it's particularly abnormal, if they're worried, then it's referred on for a hematology medical review. When we are looking at the blood films, in general, we don't know the patients. So it's very helpful to have clinical details that can make us help us interpret the blood film and then issue a report that's going to be more helpful to the referring clinician. So this is an example of a normal blood film. Can you see my cursor okay? Okay, so these pinky cells are red blood cells, so they have no nucleus. Ignore this bit of the film, which is a bit too thick, but this bit of the film here, they're kind of just touching each other, and that's where you want to look at a blood film. So these red cells look a relatively normal size and shape. They have a central pallor because they're dumbbell shaped, and I talk about the rule of thirds. So if you're going from one end of a red cell to the next, you should have pink for a third, then clear for a third, and then pink for a third. So that's a normochromic red cell. Here we've got some platelets. So these are small granular purpley cells, which also don't have a nucleus. And these are your platelets, and they should just be kind of swimming around on the blood film. And we have two normal-looking neutrophils. So these are granular cells. And when I say granular, I mean that the cytoplasm has little dots in it. So these are the granules. And the nucleus is segmented. So this has 2 segments, and this has 3 segments. So neutrophils should have about how many segments a neutrophil has, but in general it should be between about 2 and 4. Down here we've got a mature lymphocyte. This one's a little bit big, but it's a small mature lymphocyte should be about the same size as the red cell. And on the blood film we use the a small lymphocyte to help us size a red cell in comparison. And this one's normal, but actually the lymphocytes can look quite pleomorphic, so they can be big with lots of cytoplasm or small and mature with condensed chromatin like this. So now I'm going to talk a little bit about red cell abnormalities. So when we look at red cells, we talk about some things and we use big fancy words to describe them. So I'm going to go through them so that you know what I'm talking about or know what we're talking about when we report using these words. So we usually make a comment on the size of red cells. So they're usually about the size of a mature lymphocyte. If they're microcytic, then they're smaller than we would expect. If they're macrocytic, then they're larger than we would expect. And we sometimes use the word anisocytosis, which sounds very fancy, but it just means that there's a variation in the size of the red cells. We usually talk about the color of the red cells. So we'll talk about some red cells being hypochromic. So they have reduced staining and an increase in their central pallor. And we can also talk about polychromatic red cells. So these are red blood cells that have a pinkish blue tinge to them, and that's because they have residual RNA. So it's usually reticulocytes that have that are slightly more immature that still retain RNA that takes up the basic blue dye. We don't really talk about hyperchromic cells in general. We would say that they were dense cells rather than, so you won't hear the term hyperchromic usually in the blood film description. And then we talk about the shape of the red cells. So anything that is abnormally shaped is a poikilocyte. And you can have spherocytes, which are circular cells, teardrop cells that look like tears, elliptocytes that look oval or elliptical, sickle cells, and fragments. And we'll see examples of these as we go through the presentation. And finally, we sometimes will mention red cell inclusions. I don't have any examples of this, but these can be little bits of denatured DNA or denatured hemoglobin or little bits of ribosomes that can cause little inclusions in the red cell. I'm going to start just by going through some cases, and these are real cases that have come in through to the reporting room. So this was a 1-year, 9-month-old female, and the clinical data were pica and pallor. And a blood count showed a hemoglobin of 52, a low MCV at 47, a raised white cell count at 19, and platelets of 530. And this was her blood film. So here we've got a mature lymphocyte for comparison, and you can see the red cells are significantly smaller than this lymphocyte. So this is a microcytic process. I talked about the rule of thirds. If we go along this red cell, we've got very little red staining of this red cell. There's a huge central area of pallor. And here we've got these sort of elliptocytes that almost look like they have straight edges. These are called pencil cells because they look like a pencil. And it may not project particularly well, but I don't know if I can convince you that this cell here has, within the area of central pallor, there's a little bit of red in the middle to make it look a bit like a bullseye or a target. So just here, and that's a target cell. And you get target cells when you've got excess membrane compared to cytoplasm. You get sort of folding up of the membrane. So this girl had a ferritin of 2. She had a normal TTG antibody screen, so no evidence of celiac disease, and she had a normal hemoglobinopathy screen. Oops, sorry. So this girl had the diagnosis of iron deficiency anemia secondary to diet. And the typical features of iron deficiency anemia is a microcytic hyperchromic red cells. So that's these guys here. Pencil cells are very common in iron deficiency. And you can get a degree of target cells as well. Usually there's not a lot of target cells. When you have lots of target cells, and that suggests that there's a hemoglobinopathy. So when we talk about disorders of red cells, when it comes to the size, it could be small, so microcytic, and that usually is because there's some defect in heme production. So the most common is iron deficiency, where you see pencil cells, Often we look and try and make a comment about the platelet count, because if there's a high platelet count, that can suggest that there's a bleeding cause. Thalassemias, where you have a reduced production of heme, will also cause a microcytic anemia. Often there's not so much in the way of pencil cells on the blood film, but you see a lot of target cells and little purple inclusions in the red cells, which is basophilic stippling. And then the anemia of chronic disease can also cause a microcytic anemia. And they don't tend to have target cells or pencil cells, but what you will see is reactive features in the blood film. And we've got an example of that later on in the presentation. Macrocytosis, when you've got big red cells, can be either megaloblastic, and that's usually due to abnormal nuclear development, and you get kind of oval shape of the red cell. The most common cause is B12 or folate deficiency. Some inborn errors of metabolism that cause disordered B12 or folate metabolism can also cause a megaloblastic anemia. And it's also seen in myelodysplastic syndrome. In megaloblastic anemia, you get oval macrocytes and hypersegmented neutrophils. Now, this is the only blood film that I actually stole from the internet because I didn't have an example of this in my collection. But this shows an example of megaloblastic anemia. So this is a normal mature lymphocyte, and these red cells around it are huge in comparison. And here we've got a nucleus that has lots and lots of segments of its neutrophils. We've got 1, 2, 3, 4, 5, 6, 7 segments. So that is completely abnormal. So it's a very nice example of a megaloblastic anemia with hypersegmented neutrophils. Non-megaloblastic anemia, macrocytic anemia, is usually due to a variety of causes such as drugs, alcohol, hypothyroidism, and that causes around macrocytosis. And then finally, another cause of a macrocytic anemia is when you have lots and lots of reticulocytes. The reticulocytes are bigger than normal red cells, and that can bump up your MCV. And on a blood film, that will be very apparent because you'd have lots of polychromatic cells. So now I'm going to go on to the second case. So completely different. This is a 10-year-old boy, and the clinical details were pallor. He had a hemoglobin of 39, so it's no wonder that he was pale. White cells and neutrophils were normal at 7.2 and 4.4, and his platelets were normal at 352. This was his blood film. So you can see there's not very much on it. So there's very few red cells around. This is a normal, we don't have a lymphocyte to compare, but these red cells are normal in size and they have central pallor. What you also have, however, is these very dense, quite darkly red cells without any evidence of a central pallor. And these are spherocytes. And you get spherocytes when you get bits of the membrane being taken off, and so the red cell is smaller than normal. They lose their biconcave disc shape and become spherical. And what we see here as well is a polychromatic cell. So this is a reticulocyte with its pinkish blue staining. This is it up close. So you can see here a nice example of a spherocyte which has lost its central pallor, and a polychromatic cell here and a polychromatic cell here that just has a little bit of a bluey tinge to it. For this degree of anemia, one would expect if you have a functioning marrow that you'd be churning out a lot more of these polychromatic cells in an attempt to try and compensate for the severe anemia. So what other tests did we do? So he had a slightly raised bilirubin. His LDH was raised, but his DCT, his Coombs test was negative. So this wasn't an immune-mediated process. And his reticulocytes were inappropriately low at 12. And then he had a serology done, and he was parvovirus IgM positive. So he had a diagnosis of known hereditary spherocytosis with intercurrent parvovirus infection. And the examples of red cell abnormalities we can see are polychromatic cells, spherocytes, and the fact that it's a thin film with not very much on it. So hereditary spherocytosis is a sort of membrane disorder, and there's quite a lot of proteins in the red cell lipid bilayer that are involved in ensuring that there is structural integrity of the red cell. So we've got these interactions up and down the lipid bilayer, and these interactions that go sort of across the cytosol. And in general, if you have problems with these vertical interactions, the result is hereditary spherocytosis, so spherical red cells in the blood film. If you have problems with the horizontal interaction, then that tends to cause hereditary elliptocytosis, and instead of the red cells being small and spherical, they're long and oval or elliptoid shaped. Usually these are autosomal dominant conditions. You can get rare autosomal recessive conditions, but that tends to cause bizarre looking red cells on the blood film. So usually is a relatively mild condition. Patients have a compensated chronic hemolytic anemia, and we just treat them with folic acid. Some people have more severe phenotypes, need a splenectomy to try and lengthen the red cell lifespan. And some children who have lots of gallstones may need a cholecystectomy. Interesting with this child was that he had parvovirus infection. So parvovirus will in anyone cause a temporary cessation of erythropoiesis, which lasts about 7 to 10 days. So you don't make any red cells for 7 to 10 days. And in people who have a normal erythropoiesis, that's okay because your red cells would normally last 30 days, and so you've got enough red cells to tide you over until your erythropoiesis recovers. When someone with any sort of congenital hemolytic anemia, their red cell lifespan may be as short as 15 days, and so they don't have that reserve. Case 3, this is a 6-year-old boy whose presenting clinical details was jaundice. So he was anemic, he had a hemoglobin of 67, a white cell count of 17, neutrophils of 13.4, and platelets of 563. And this was his blood cell, sorry, his blood film. So we've got some normal looking cells here, but can I convince you that this cell here looks like it's had a bite taken out of it? It looks a bit like a Pac-Man, but like something has taken a bite out of that cell. And you can't see it, so I didn't do a close-up of it. And then here and here, and probably better here, it looks like this, like the red staining of the cell has been squished to one side, and then there's one side of the red cell that almost has no hemoglobin in it, no staining. This is called a hemighost. And you get these changes when you have denatured hemoglobin that get bitten out of the cell when the red cell passes to the spleen. So he had a raised bilirubin, so he had a hemolytic process. His LDH was raised at 622, and he was DCT negative, so not an immune-mediated hemolysis. And it turned out that he had low G6PD. So the diagnosis in this boy was G6PD deficiency with an intercurrent illness. And the changes that we can see are bite cells, so these guys here, hemighosts, where part of the red cell seems to be empty of any staining, and there are a few little spherocytes dotted about as well. So there are a multitude of red cell enzymes that help ensure that the red cell functions normally. The majority that can be disordered and cause problems with hemolytic anemia are those involved in the pentose shunt, which protect the red cell from oxidative stress, and those involved in the glycolytic pathway that provide the red cell with energy. The most common enzymopathy that we see is G6PD deficiency, which is an enzyme of the pentose shunt. It's an X-linked recessive disorder, and it's predominant in African, Afro-Caribbean, Mediterranean, Indian subcontinent, and Southeast Asian people. And the reason that this is a survival benefit is it reduces the severity of malaria. And it presents as intermittent hemolysis triggered by oxidative stress, such as infection, certain foods, certain drugs. And it can also present neonatally as neonatal jaundice. Interestingly, G6PD levels may be normal in an acute hemolysis, because in acute hemolysis, usually the bone marrow is churning out reticulocytes that actually have relatively normal levels of G6PD, so you can mask a low G6PD level. So if you have a high suspicion of G6PD, the G6PD level should be repeated when the patient is well to get an accurate enzyme level. The next most common enzymopathy is pyruvate kinase deficiency, which is an enzyme of the glycolytic pathway. This is also an autosomal recessive disorder, and it causes usually a mild chronic hemolytic anemia and can also present with neonatal jaundice. This has less typical red cell morphology. There can be a bit of anisocytosis, so a difference in the red cell number, some polychromasia, some large cells, but usually there are no spherocytes, no bite cells, and no hemighosts. So, case 4, this was a 9-month-old female whose clinical details were unwell in PICU. She had a hemoglobin of 60, white cells of 3.5, neutrophils of 1.9, and platelets of 20. And this was her blood film. So what we can see here are normal red cells, a few spherocytes, but then these things that look like red cells but have a very sharp edge. There's another one here, and you can see here it's got a very sharp, straight edge. And these are red cell fragments. She had an abnormal clotting and a very high D dimer. And it turned out that she also had group A strep sepsis. So this girl had disseminated intravascular coagulopathy secondary to group A strep sepsis. And the things that we can see on this blood film are red cell fragmentation. And what you don't see is any platelets. So in this sort of a field, I'd expect to see about 3 or 4 little platelets, those small purple dots that we saw on a normal blood film, but she doesn't really have any. So she had a genuine thrombocytopenia. So red cell fragmentation is something that we see quite often, and it's usually due to mechanical trauma of the red cells, either due to valves, for example, or for fibrin sheaths, or something in the vasculature that's churning the platelets and shearing them. Sorry, not the platelets, the red cells. So when I am thinking about red cell fragmentation, the tests that I do, or I think that should be done, are a hemolytic screen to confirm that there is red cell lysis. So if that's positive, you'd expect there to be a high LDH, low haptoglobin, a high bilirubin, high reticulocytes. Usually in a fragmenting condition, usually the DCT is normal because it's not usually immune mediated. I then look at a coagulation screen. If that is abnormal, this is likely to be DIC, and you look for an underlying cause and treat it because that's what's going to resolve the fragmentation. If clotting is normal, I look to see if there is thrombocytopenia. And if there is, then you're looking at a microangiopathic hemolytic anemia. If there's renal impairment, the likelihood is that it's HUS. If there's neurological component, then that's usually TTP. And if it's post-transplant, then it's likely to be transplant-associated microangiopathy. If they have a normal clotting and a normal platelet count, then look for external mechanical breakdown. So what I have seen is metallic heart valves can cause fragmentation of the red cells. And if it's causing a hemolytic anemia, which is transfusion dependent, that is a sign that the heart valve needs to be replaced. Okay, so case 5. It's a 3-year-old female, and the clinical details was routine. And this was a routine blood film from Dr. Pinto's clinic, so I knew that there's probably some hematological problem going on. The hemoglobin was 92, the white cell count was 12.9, neutrophils were 4.5, and platelets were 356, so a mild anemia. And the MCV was normal at 77.4, but just, low normal. And this was her blood film. So we've got normal red cells here, but you can also see a lot of these funny looking cells that are, well, hopefully I can convince you they look like a sickle. So like I guess a sickle to shear wheat. So these are sickle cells here. And then we also have these cells, which are called boat-shaped cells because they look like the underside of a boat. And this is basically typical of sickle cell disease. And her hemoglobinopathy screen showed a high percentage of hemoglobin S. She also had quite a high percentage of hemoglobin F as well, and still had some normal hemoglobin A. So this is a girl with sickle cell disease, and what we can see on the blood film are sickle cells, boat-shaped cells. You can see some target cells, so that's that bullseye cell that we saw in the iron deficiency patient, but these are much more obvious here. So there's one here, there's one here, there's one here, and they look like a bullseye or a target. And there's anisocytosis, so differently shaped red cells. So, sorry, differently sized red cells. So a small one here, a normal size one here, a slightly bigger one here. So variation in the size. Now, interestingly, this girl has a very mild phenotype, and I suspect that genetically she is a heterozygote hemoglobin S and beta thalassemia. So she will probably have she probably produces small numbers of normal hemoglobin A, which will protect her from having lots and lots of sickle cell crises. I think you're probably going to get a hemoglobinopathy tutorial at some point, so I won't go into hemoglobinopathies because it's a very huge topic. So I don't know, is it questions at the end, or is there any questions about any of the red cell cases?
People can also submit the questions through the chat function, if you like.
Okay, I can't see the chat function and look at my slides. So
I'll let you know. I'm keeping an eye on it.
Okay. So that's all the examples of red cell abnormalities that I wanted to talk about today, and it's just what I had in my collection box. And again, it hopefully gives you a flavor of the kind of red cell abnormalities that we see. So I'll now go on to disorders of white cells and platelets. So when we assess white cells and platelets, we're usually looking at the white cell number, and that's usually what triggers us to look at a blood film. If there's a high white cell count, then we're really seeing if it's reactive or a malignant increase in the white cells. If there's a leukopenia, specifically a neutropenia, again, we want to see if that's because there's lots of other abnormal cells that are stopping neutrophils from being formed. Or if they look abnormal and dysplastic, and there's this disorder in actually making normal neutrophils. And then we'll look at the white cell morphology. For platelets, again, it's really about number. So a thrombocytosis in children is almost predominantly due to a reactive process. When we are referred to with thrombocytopenia, the first thing that we look at is there an artifact? Because any clot in the tube will cause your platelets to clump together and give you an artificially low platelet count. But we also look for evidence of any bone marrow suppression, drugs that might be affecting the platelet count, looking for consumptive evidence of platelet consumption. So I'll just go through the cases. So this was a 3-month-old male, and the clinical details were tachycardic and tachypneic. We had a pretty normal hemoglobin, 116, a high white cell count, a high neutrophil count, a high monocyte count, and a very high platelet count, almost 1,000. And this was his blood film. The first thing that you can see, it's very obvious to see that there's lots of platelets around. So there's lots of these small purpley dots in the blood film, and these are platelets, and there are a lot of them. The red cells, rather than kind of being apart, seem to be sticking together in lines, almost like a stacked up, like a stack of coins. And this is rouleau. This is what we call rouleau. And rouleau happens when you have any increase in the plasma kind of viscosity because of protein. And often in a infection, you can get that because you've got immunoglobulin in the plasma, and it can cause the red cells to stack together. What we can also see is 3 neutrophils. So this one looks relatively normal, except it's only got a couple of segments. This one's only got a couple of segments, maybe 3, and this one's got a couple of segments. Remember when I said usually neutrophils have 2 to 4 segments, and here you've got 3 examples of neutrophils, and they seem to have fewer segments than we would expect. The more segments you have, the more mature the neutrophil is. So this suggests that the neutrophil is slightly less mature than what we would expect to see in a normal film. This neutrophil has these pinky granules, which you would expect. So does this neutrophil and this neutrophil, but these granules are very dense, and there's a lot of them, and they're quite chunky. And this is what we call overgranulation, and we call this toxic granulation, and this happens in response to infection. Again, we've got a nice example of some very granulated neutrophils here. We also have some monocytes here with little pale dots in the cytoplasm. This is vacuolation. And this is another reactive feature that you can see post-infection, little vacuoles of lipids in monocytes and neutrophils that are full of either lipid or cytokines or whatever, ready to be released to fight infection. I don't know what this patient had in the end, but I know that they were septic. And the features that we see in the blood film, which are all reactive changes, are thrombocytosis, rouleau, which is the stacking of the red cells to look like stacks of pennies, neutrophil left shift. So anything towards the left of maturity is immature, and anything towards the right of maturity is more mature. So when we talk about neutrophil left shift, we're saying that slightly earlier neutrophils are being seen, which suggests that the bone marrow is churning out neutrophils as they make them because they're responding to an infection. We're seeing toxic granulation. This hasn't projected so well, but there's a little area of bluishness in the periphery of these neutrophils. These are Dolly bodies, and this is something that is also seen in response to infection. We're also seeing monocyte vacuolation. So these are all reactive changes that we can see in blood films. This is another case of a patient with a reactive condition. So this was a 4-year-old boy, and his clinical details were non-blanching spots. Again, he had a slight anemia. Hemoglobin was 106. White cells were 14.8. Neutrophils were slightly low at 1.1. His monocytes were raised at 1.8, and his lymphocytes were raised at 11.6. And he had a normal platelet count. And this was his blood film. So the red cells look okay. There's going to be a bit of rouleau here. The platelets look okay. We've got a normal lymphocyte here. And then here we've got this very large cell that looks nasty and big. So big cells we don't really like on a blood film. Cells where the nucleus looks quite open and a paler purple we don't like, because that suggests that things are immature, because the chromatin, when it clumps together, your chromatin clumps together when it's mature and it takes up the dye, it results in a dark purple nucleus. When it's a paler purple, then it suggests things are a bit more open and a bit more immature. And there's a hint that maybe there's some machinery going on in a nucleolus. This cytoplasm has a blue edge and it's scalloping around the red cells. And that's quite typical of atypical lymphocytes or reactive lymphocytes. This patient also had some slightly more bizarre cells around. So this cell here and this cell here, I don't really know what they are. They look a bit like they could be a reactive lymphocyte, Then the cytoplasm also looks like it could be something like a monocyte. So I don't really know. They just look a bit atypical. They just look not right. And then here, I don't know what this is, but it doesn't look right. The chromatin is open. There's maybe a nucleolus here. It's a cleaved nucleus. It doesn't have very much cytoplasm. It's quite big. Is this a blast? Is this an atypical lymphocyte? It's hard to know. So we did a bit of digging and we did a monospot test. So EBV infection can cause bizarre looking lymphocytes. The monospot was negative. So we sent this blood film for flow cytometry, and then in flow cytometry, what they do is you look at markers at cells to see if there's a monomorphic population or a polymorphic population. And what the flow showed that these cells are probably polymorphic T cells. Something that's polymorphic is less stressful than something that's monomorphic because it suggests that it's a reactive thing. And then we did a serology, and it turned out that he actually had, he was positive for EBV IgM. So this is actually acute EBV infection, but the cells in an EBV infection can be very bizarre and can mimic leukemia. So we've got reactive changes. So we've got these rouleaux stacking of pennies. We've got reactive lymphocytes, but we also have these atypical mononuclear cells. So that's reactive changes. I'm now going to go on to a malignant infiltrate in the blood film and what we can see in malignant hematological disorders. So leukemia means an increase in circulating white cells, and if it's an increase in acute immature blasts, then that will be an acute leukemia, and there's acute myeloid leukemia or acute lymphoblastic leukemia. And acute lymphoblastic leukemia can either be B or T cell. If there's an increase in in mature cells, and that's a chronic leukemia. And then some lymphomas can have a leukemic component as well. So it's usually a combination of morphology, immunophenotyping, and genetics that allow us to diagnose and subtype hematological malignancies. So this is the first case. So this is a 2-year-old female who presented with a LIMP. She had a hemoglobin of 97 and a slightly low platelet count of 169, but a huge white cell count of 73. And this was her blood film. So she has, here's a red cell for comparison. She has these huge cells in her peripheral blood, and this is them up close. So they're huge. They have a very big nucleus. They have a lot of nucleus compared to cytoplasm. So that's a high nuclear to cytoplasmic ratio. And in the cytoplasm, you can't see any granules. So these are large agranular blasts. We did her flow cytometry, and she was positive for CD34 HLA-DR, which are immature markers. She was positive for CD79A, 19 and 10, which are B-cell markers. And she was negative for MPO, CD30, and CD11B, which are myeloid markers. So she has large agranular blasts, doesn't have much else, and she's typing for B cells, immature B cells. So this is a case of B acute lymphoblastic leukemia, and it's a nice example of medium to large agranular blasts. Similar case, this is a 3-year-old boy that presented with lymphadenopathy and bruising. He had a low hemoglobin of 79, a platelet count of 60, and a very high white cell count of 128. And this was his blood film. So very similar to the one before. These again are agranular blasts, so no granules in the cytoplasm. They're blasts because they're big. The chromatin is open, and there's here a nucleolus and here a nucleolus. And some of the nuclei look like there might be a bit of a fold in them. So maybe the nucleus is folding in on itself. He had a very high LDH, and his flow was positive for CD5, 8, 4, double positive 4 and 8, 2 cytoplasmic CD3 and cytoplasmic CD7. These are all T cell markers. And he was also TDT positive, which is an immature marker. This patient has immature blasts, agranular blasts, and he's typing for T cells. This was an example of T acute lymphoblastic leukemia with small to medium agranular blasts. But I have to say that when we're looking at blasts under a microscope, it's very, very hard to say if something is a B cell or a T cell, and really what you need is a flow cytometry to clarify which one it is. So acute lymphoblastic is due to the proliferation of a lymphoid stem cell clone. It's one of the commonest of childhood malignancy. 25% of childhood malignancies are ALL, and this it accounts for 80% of childhood leukemia. And about 85% of them are B cell, the remaining 15 being T cell. Presentation is usually non-specific and specific. The children can present with a limp, with pallor, with just not being quite right. And the treatment is intensive chemotherapy, and at the moment they are treated as part of the, as per the UCAL 2019 guidelines. And treatment is stratified by measuring their minimal residual disease. So we have very good success in ALL treatment because we are able to tailor treatment based on very sensitive markers of patient response. And the outcomes are very good. We're looking at upwards of 90% 5-year overall survival, and most of those survivals are long-term cures. This is another case. This is a boy who is 4 years old, and he presented with pyrexia. Hemoglobin was 46. White cell count was high, 66, and his platelet count was 13. This is his blood, this is actually his marrow. So we've got red cells for comparison. What you can see are these huge, huge immature cells in his bone marrow, huge. They have an open chromatin, so it's quite, it's not densely purple nucleus. Here we've got a erythrocyte, a mature erythrocyte to compare. So you see how dark that nucleus is. This nucleus is a lot more open and paler purple. They have nucleoli. And we can see here, there's some pinky staining in the cytoplasm. And here as well, there is pinky staining in the cytoplasm, similar to the pinky staining that you get in neutrophil. So these are granular blasts rather than agranular blasts. So we're thinking that possibly that this is a myeloid type of leukemia rather than lymphoid because of the granulation of the blasts. And the flow cytometry mirrored that. So he was positive for CD34 and HLA-DR. So that's telling us that it's an immature thing. And he was also positive for CD117, MPO, and 33. So MPO and CD33 are myeloid markers. And he was negative for the B cell markers CD19 and 79A. This is an example of acute myeloid leukemia with large blasts with a variable degree of granulation and also a little bit of myeloid differentiation. So you can see here a normal, probably myelocyte here. So again, I know you're going to have an acute myeloid leukemia session, so I won't go into detail about AML, but AML is due to a proliferation of a myeloid stem cell clone. It is a heterogeneous genetics and morphology, and it accounts for about 20% of childhood leukemias. Again, presentation is usually non-specific. And again, the treatment is intensive chemotherapy, and currently children in the UK are treated as per the MyChild 01 clinical trial. The outcomes for AML are not as good as ALL, and there's probably about a 75 to 80% overall 5-year survival. So this is case 8. It's a 2-year-old girl who was incidentally found to have splenomegaly. This is one of my patients who went for an ultrasound scan to assess her kidneys because she'd had a UTI. They found that she had a spleen down to her umbilicus. With a hemoglobin of 71, a white cell count of 360, and a platelet count of 167. And this was her blood film. So what you can see here are neutrophils, but you can also see what looks like a granular cell, but it's not got the normal segmentation. We've got some neutrophils here as well. And then here we've got another type of white cell that is very, very, very granular with deeply staining purple granules. This is a basophil, and In general, you shouldn't see a lot of these in the peripheral blood. And if you do, then you are thinking there's something wrong with the myeloid system. This here is probably a myelocyte. Before you get to a neutrophil, the earlier stage is a myelocyte. And if the bone marrow is churning out myelocytes, then that's also abnormal. So she's got left shift. She's got basophilia. So when we did her diff, she had a basophil percent of 3%, a blast percent of 1 to 2%, and she had a big spleen clinically. And on her genetics, she was positive for the Philadelphia chromosome. This is a case of chronic myeloid leukemia in chronic phase. And what we can see here is an example of leukocytosis, left-shifted myeloid series, so churning out early neutrophils and myelocytes, and basophils. This is another example of one of my patients. So a 10-year-old male who presented with leg pain and ephemeral mass. Actually, I apologize, that is not his counts. He had a relatively normal count. But this was his bone marrow. So you can see neutrophils, probably a neutrophil, probably a metamyelocyte. So these are all part of normal myeloid maturation. A basophil here, but then these cells, which are big and have an open chromatin, have a nucleolus. So these are myeloblasts. So he's got a lot of blasts. And even in your bone marrow, you shouldn't have a lot of blasts around. Anything upwards of 5% is abnormal. When I did his count, he actually had a blast count of over 20%, and he was also Philadelphia chromosome positive. So he also had chronic myeloid leukemia, but he was in blast crisis. So his chronic myeloid leukemia had transformed into an acute leukemia. And again, we can see left-shifted myeloid cells and basophils, but also now a lot of myeloblasts. So chronic myeloid leukemia is a myeloproliferative neoplasm which is characterized by the Philadelphia T922 translocation, which results in a BCR-ABL fusion and a BCR-ABL fusion protein product, which means that the ABL tyrosine kinase, which is an oncogene, is always turned on. It's a rare disease in children, and we see it in about 2% of children under the age of 15 and about 9% of children between 15 and 19. So we're quite unlucky to get 2 CMLs in the space of about 3 months. Usually CML has an insidious onset with non-specific symptoms, and sometimes they have quite marked splenomegaly and a high white cell count because they're actually very well. And the film features are leukocytosis, a left-shifted myeloid series with myelocytes, often a thrombocytosis, eosinophilia, and basophilia. And then in terms of typing what stage they're at, it's all about the blast count. So if you have less than 5% blast, and that's chronic phase, between 10 to 90% blast, you worry that the patient is in an accelerated phase and about to transform into an acute leukemia. And if you have blast of greater than 20%, that's blast crisis. And the treatment is usually with a tyrosine kinase inhibitor, such as imatinib. And for some people, just long-term tyrosine kinase inhibition is enough to control the disease. But especially in children, where you're looking at being on these kind of drugs for a long time, often the drugs will fail after a period of time. So a lot of children need to progress to a stem cell transplant for ultimate disease control and cure. Children that have blast crisis or accelerated phase CML have to be consolidated with the transplant because their risk of relapse is high. So this is my final case. This is a 9-year-old female who presented with a mediastinal mass. She had a reasonable count. Hemoglobin was 96, white cells 8.8, neutrophils 4.5, and platelets 130. Her blood film was relatively nondescript. She's got a myelocyte here, so there's some left shift in the myeloid series. That may be because there's some problem in the myeloid lineage. That may be because she has a stressed marrow and she's reacting to something. But when we did her bone marrow, she had these large blue blasts in her marrow. So these are, again, huge. There's a high nuclear to cytoplasmic ratio, but there's still some cytoplasm present. And the cytoplasm is intensely blue with multiple vacuoles. So these little vacuoles here. At a high LDH, and her flow was positive for B cell markers, which are 19, 20, 79A, CD10, and FMC7, but she was negative for TDT. So an ALL, an acute lymphoblastic leukemia, is usually TDT negative, is usually TDT positive because it's a marker of immaturity. What this girl had is Burkitt's lymphoma, and these cells are very typical of Burkitt's. It almost can't be anything else. So what we can see is left-shifted myelospheres with myelocytes. We've got some abnormally shaped red cells here that look a bit like a teardrop. So the bone marrow is in distress when you have teardrops in the blood film. And then we've got these Burkitt cells that were in the bone marrow. Burkitt's lymphoma is an aggressive high-grade mature B-cell lymphoma, and it's characterized by the 814 translocation, which translocates the IgH heavy chain gene onto the MYC gene. MYC gene is then overexpressed and has oncogenic properties. And it's as common as non-Hodgkin's lymphoma in children. The presentation is often with a mass, usually abdominal. This patient presented with a mediastinal mass, which is slightly atypical for Burkitt's. And usually these patients are sick. They have systemic problems. They've had weight loss. They've got B symptoms. They're pyrexial. They're lethargic, and they're just unwell. And again, the treatment is with intensive chemotherapy, and treatment has improved greatly over the last decade or so with the introduction of rituximab to conventional chemotherapy. Rituximab is a monoclonal antibody against CD20, and that has really increased up the overall survival from Burkitt's lymphoma. Now we're looking at outcomes of upwards of 85% 5-year overall survival. And again, the majority of them have complete cure. So stop sharing. So that was a kind of whistle-stop tour of some of the morphology that I have seen in my time in the last 3 years in my collection. It is not exhaustive by any means, but it just shows you the flavor of stuff that we get in through the lab, and how having the clinical details to marry up with what we see in the blood film is really useful, because it really changes the quality of the reports that we can produce. Similarly, hopefully now that you know what we mean when we say teardrop red cells or fragments or anisocytosis, and it can give you a sort of picture in your mind of what we are seeing under the microscope when you see the report. I don't know if there are any questions just now. Maybe not.
Maybe not from the room. I'm just seeing if any of our participants have. Thanks, that was a very nice talk. It was really nice to see them through the case perspective, and to see all the kind of the breadth of things that you can read from a film. There's nothing on the chat function, so maybe there's no questions today. But as always, we'll record these sessions and make them available, and we might have any follow-up questions in the future. We might direct to yourself if need be.
Okay, great. Well,
we'll try and collect some feedback for this talk as well, Shahzya, and make it available to yourself. Thank you very much for doing this session. It's been very useful.
Okay, that's great. And for anyone that is rotating through Shahal, we do try and do morphology sessions. So if you do want to see anything in real life down a microscope, then let myself or one of the other hematologists know, and we can facilitate that. Okay.
Thank you very much.
Okay.